all, it's my great honor to be here, and I'm very happy to share with you our experience. And please call me Nancy. I'm from National Taiwan University Hospital, Taipei, Taiwan. And in the next 20 minutes, I want to share with you, the first is our experience in newborn screening. And I will briefly introduce you our newborn screen system. And second, I will focus on the experience of our screen-positive babies and how about them currently. So the first thing I want to make a brief introduction is about our newborn screen system. I think we have the advantage that because we here, Taiwan, you can see that, I know. We are located at a very populated islands, and that makes the distance is not a big issue in our newborn screen system. So currently, we have the newborn screen system is around almost 100% coverage. That means every baby in our island or in our country can have the newborn screen immediately, and they can have the report in 7 days in average. And I think another advantage we have is that we have the Rare Disease Act, so every baby can be covered by the National Health Insurance so that they can have the treatment immediately. So that makes my journey in Pompe disease is that you already heard about the natural history studies, and at that time we or I start to be involved in this in the Pompe studies that we learned about the natural history of infantile onset Pompe disease, and we also have the chance to be participate in the pivotal clinical trial of okay, here. So because we also run the newborn screen lab in our hospital, and we took care of around 40% of newborn babies born in our country. So it's quite a chance that we think about that, because we have the newborn screen laboratory in our centers, and we also have we cannot show that. We also have the clinical unmet needs.
It doesn't like that slide.
Okay. So it's quite simple, quite easy to think about that. We probably may be able to combine two needs, that we can do newborn screen to early diagnose those babies, and then we can have the treatment immediately. So, okay, that's fine, thank you. So here I want to show you is about the natural history in our population. You already heard about the infantile onset Pompe disease. It's quite a rapid progressive disease. But also in our population, in Chinese, I think that we have a more advanced or more rapid progressed clinical course compared to your experience, that in average, our patient need to be on ventilator if they don't have the treatment. In average, they have been ventilated at the age of 22 years old. So we think that we probably have a more severe phenotype in late onset Pompe disease. So here is one perfect example I want to show you. I know that you have some newborn screen laboratory person here. You can see that this is a baby we identify through our newborn screen. And in our system, that the baby have the first sample collect at the age of 3 days. And it needs 1 day to transfer the sample to our lab. And we can have the report in 1 to 2 days. So at day 6, we notify the parents that please bring the baby back to our hospital. We need to do a second check. And I'm quite agree with Dr. Russer that dry blood spot is very informative, but we need other things to make sure the diagnosis. So when we brought the baby to our hospital, actually we do a lot of things in 1 day. It's very intensive. You see that we easily identify the baby have a heart problem, but at the same time, we need to repeat the enzyme assay by leukocyte to confirm the diagnosis. And we also need to do the genotype, and it turned out the baby doesn't have the common mutation in Chinese that predict a cream positive status. So in that baby, we also need to do the cream test in whole blood. So it took us 1 day to prepare for everything, and we can do the first enzyme replacement therapy at day 8. So that's a perfect example I want to show you. And it may not go so smoothly in other cases. And here is our current algorithm. As I say that if we have abnormal dry blood spot result, we need to do everything. And if the baby has infantile onset Pompe disease, classical with cardiomegaly, we can do the treatment immediately. Or we need to follow the case because they have enzyme defect, and we need to do the follow-up to see when should we start the treatment. And here is our outcome in infantile onset Pompe disease. You already know that if we can do the treatment, it can largely change the natural history. So this is the overall survival here with clinical diagnosis and then give them treatment. But in those infantile onset Pompe disease, we identify through newborn screening. Currently, they all survive and they don't need ventilator. What does that mean? That means the baby can be like that. You already know that they can survive. They don't need ventilator. They don't need gastrostomy. They don't have the heart problems. But they still have some muscle weakness. So for example, this one needs to use the walking ad, but this one is quite good. So this is the current situation we have compared to 15 years ago when I met these babies. We usually have something like that. The baby was so weak. And even we gave the enzyme replacement therapy at that time, you still observed the severe motor impairment. But currently, the baby with newborn screening, we can see that she is very strong and work good, but it is not everyone have this kind of response. So even with newborn screening, this one can have such good response, but this one at the age of 2 years, she already have some proximal muscle weakness. So it tells us again that not everyone responds similar. And we want to find out what's the reason. So we monitor the baby's response after treatment. As you know that the enzyme replacement therapy doing very good to the heart, so they don't have the heart problem currently, although we know the risk of arrhythmia, but none of them present arrhythmia. However, in the muscle part, you can see that we have the biomarker, the CK, indicates muscle damage. All of them can have nicely decreased after treatment, but then increase again. At the same time, their motor function slowly declined compared to normal. So when we did the muscle MRI to see what happened in those babies, we can see that they have quite significant muscle signal changes. That's fine. Forget about it. We can see the muscle MRI change significantly, and we noticed that if we can do earlier, the muscle change seems to be improved for a while. And also, for those cases, if we can increase the enzymes dosage, the muscle seems to be improved a little bit better. So currently, we increased the treatment dose to 40 milligram every other week, try to see if they can have a better outcome. But my message here is that if we can do newborn screening, we can buy some time. So even the case here, I'm showing you, this baby increased the dose at the age of 3, and at the age of 6, you can see he presents some muscle weakness, abnormal gait, but he could run. And at the age of 10 years, he's still ambulatory by himself. So with newborn screen, even without increase the dose, we still have good time, at least for 10 years. And currently we do increase the dose initially, and so we will wait to see if they can have even better or longer good time. However, we also have others challenge, and I need to tell you that exercise is very important. So in our case, they all have articulation, the speech problems, so they have very bad hypernasality, and it makes us difficult to understand what they are talking about. But you see here is that if we can do the exercise, and if they can exercise compliance very good. For example, this one, you can see that after exercise of the speech therapy, the correct consonant is increased quite nicely. And the other option we need to do is to do the increased dose. For example, this one, with speech therapy, this one can have improvement in the correct consonant speech, and with even with the increased dose, the effect may be even better. So exercise, for example, the speech therapy and the increased treatment dosage are two things that we are trying to do to improve their outcome. And the third thing is that they may have the white matter changes, as you already heard about, that all of them have the white matter changes, and that is slowly progressive. But this one, even he showed the white matter changes, he has excellent school performance and even have the award. So it doesn't mean that with white matter changes, it definitely affects the cognitive function, but we need to have more studies and more follow-up on this. And the last thing I want to mention about infantile is the neuropathy. As you heard, that they have some distal weakness, the foot drops, and we should be able to see some angular fibers because of the neuropathy. And indeed, our neurologist to take care of the muscle biopsy initially, and we found that at the age of 6 months, they already show those angular fibers, indicate some neuropathy changes. So it probably is a new thing that we need to think about how to improve the neuron involvement in those infantile onset patients. And the last thing I want to mention is about the late onset Pompe disease, because using the dry blood spot, we can measure the enzyme defect in every babies. But besides those infantile onset Pompe disease, actually we have others group. Indicate here is the so-called late onset, but we don't know when they present symptoms. So the only thing we can do is to monitor them since the very beginning. And we know that some of them have the CK elevate, and some of them have the muscle, the motor function. It doesn't like it. So that's fine. So so the only thing that we can do is to do the monitor. But I want to tell you is that some of them actually have nothing. For example, this one, very strong trunk muscles, and this he even can do the sit-up quite nicely compared to others patients. So this one, because of the borderline biochemical laboratory, so we start the treatment at the age of 3 years. But you see that he still have some trunk weakness. And this one, because we identify her through newborn screen, and we her CK elevates quite earlier, so we start the treatment at the age of 4 months, and she now can play badminton, and she won a champion. Very strong, but you still see something happens in her. So we try to use a different combination to decide when should we start the treatment. And okay, so we try to do a combination assessment from the genotype, from the urine group 4, from the CK, and also from the our motor evaluation, try to find the right time or the earliest sign to start the treatment. But not everyone needs treatment. So we need a very good follow-up system, and we try to find the time to treat, and we also need to cope with those pre-symptomatic or symptomatic patients. But for those with treatment, we need to think about if we have the time to do the immunomodulation, and what's the dosage good for them, and what's the long-term and the short-term outcome. And for the screen part, I need to emphasize again is that we need to make sure the timing is good, and we can do the treatment as early as possible, but at the same time we need to minimize the false positive and false negative things and make a good positive prediction rate, because once we say this is a positive screen result, we need to have an intensive evaluation to that babies. So here is our group that we need to think. I need to think about all of my colleagues, the dietitian, the genetic counseling, the rehab, and also the speech therapist help. And this is what they look like now. You see that they are young, but they don't need walking. They don't need to have the, currently they don't need the ventilators again, and they can walk by themselves. And I hope that in the future we have next generation therapies and we can understand more about them. And thank you so much.